No.
Okay, so we prepared the additional very interesting case, and for this case,
this case is 13. 13.
Yeah, 13. Yeah, 13.
Okay,
cases.
still long way to go.
Yes.
All right. Let's explain that one.
Okay, for this case, we invited the imaging specialist, Dr. Jung-Sun from Severance Hospital, and then I think this case is very helpful. How do imaging guided PCI impact the real clinical outcome? Is the result of angiography guided PCI and imaging guided PCI. Okay. Dr. Yeung, can you start this case?
Yes, this patient is 74-year-old male and came to our clinic for abnormality of thousand speck. Actually, he underwent the PCI at left main bifurcation. It was done by pre-stenting 9 years ago in the other hospital. 1 year later, he underwent the kissing DV angioplasty to ISR. At this time, his coronary angiogram showed diffuse ISR at proximal to middle LAD and circumflex stent. And FFR level for LAD was 0.49 and circumflex was 0.9. Next. And he has hypertension and dyslipidemia. So his clinical presentation was silent ischemia.
Yes.
Next.
Okay, so I'm going to summarize this patient. This patient, the 74-year-old male, presented no definite recurrent chest pain, but Salyum scan shows the large defect area in the LAD and also SOC. And yes. So, and looking at the coronary angio, this patient is underwent a V-stent at 10 years ago in another hospital using Promo stent. And then at the time, the SOC put the Promos 3.515, and the LAD from the mid to the LAD ostium, 3 Promos stent 2.5, 2.75, 2.75. I guess at the time might be due angiographic guided PCI, the reason why 2.75 put the LAD ostium. And then next, looking at that, this is area coral view, we can see the V-stent like shape, but very diffuse region in the sarcosteum and LAD. And next, looking at the V-stent, this is a spiral view. We can see the significant narrowing of the mid-LAD and diffuse neointimal hyperplasia and the sarcosteum. And the next. Okay, this is the, some areocranial view. We can see the very diffuse region and calcified region, very mid-LAD part is a very tight region. So, and if you guess 2.5, 2.75, 2.75 is too much small in the, contrast to our common sense, it might be angiographic guided PCI. So next. So, and we decide to, this patient is the OCT guided PCI because we invited OCT specialist. So we did the OCT registration, angiography co-registration, and then thoroughly checked what's happening at the time. Is some under-expansion, something like that. We checked the OCT from the mid-LAD to left main and the SOC or left main. Okay.
I think this case is one of a good candidate for roto ISLs, our randomized studies. Would you?
Yeah.
What do you think? Would you do that? No?
Yes. Yeah. We consider. Okay. This is the patient is the randomization to just balloon angioplasty.
Balloon angioplasty. Right.
Okay.
Good luck.
We checked OCT is a profile scheme, and can you explain what happening is interesting?
Yeah.
Is what finding is interesting?
Yeah. Good afternoon. I'm Jung-Sun from Severance Hospital. I would like to show the OCT image. Here is a distal part. As you can see, this one.
Yep.
Yeah. Here is a distal. Yeah, LAD. So as you can see, the LAD length is around at least 30. So I think this stent is too small for this vessel. So also we check the OCT. Here is a distal. Distal part of the stent. Most of stent is underexpanded. Its stent length is around 1.8 in this patient. And some part is there is some significant neointimal tissue growth as shown this part. But most of the entire stent is underexpanded. So I think it's
You
better
mean
to
compare with the different distal reference vessel size.
Yeah, that's right. This
Underexpansion,
reference size is
small.
around 30.
All right.
And also this stent is a 2.5 and 2.75, but this stent
All
is
right. It's very
expand
small.
to the
2.0
1.8.
something, right?
Yeah.
All right.
Is Dr. Kim, is there any neoatherosclerosis finding or some calcified
this kind of finding is a possible neoatherosclerosis. There is a possible macrophage inflammation, or there is some low attenuated plaque and calcified here. So I think it's possible, some neoatherosclerotic findings. So we can do the balloon angioplasty in this case at first, and then if it's not adequate, we can do some another measure. But I think a main mechanism is under expansion, so we need to expand the stent at first.
And 2.75 and distal part 2.5, 2.75. So initial angio, we checked FFR from the mid-LAD to the left main is FFR drop down 0.49, definitely significant region functionally. At the time, looking at our initial diagram, can you see the diagram? Okay, look. Text image. Fax image. Okay, looking at the FFR value. Okay, looking at the baseline measurement of the sock region, and there is FFR drop down 0.9. I think there is some discrepancy of the FFR value and the imaging finding.
Circumflex is good, you mean?
Yeah, okay.
Right.
Here is a circumflex image.
코 레지스트레이션 하는 거 보여줘봐. 이 엔지오를. 그렇지. 우리 코 레지스트레이션 하는 거. 여기 서커 볼 때. 전에.
Do you have co-registration?
Okay, here we did co-registration for SOC and then check the IVUS pre-intervention. Okay, can you explain the SOC finding?
Circumflex artery.
SOC FFR is 0.9.
Yeah, from distal, pull back from distal to the left main. So this stent is also somewhat underexpanded, but there is a significant amount of the neointimal tissue, as you can see here. So minimal lumen area is 1.26.
1.26.
Yeah.
Minimal lumen area.
Yeah, lumen area.
1.26.
Around
FFR was
1.3.
0.9.
Yeah.
Lumen area.
How could you already mean diameter, you mean? Area?
No, area, lumen area.
Lumen area is less than 3, less than.
How could you know that?
Okay, this is automatically measured.
Yeah, here.
All right.
1.2
Red
to
color
9,
1.3
square millimeter.
Very small minimal
So
lumen
yeah,
area,
but
right?
it's quite there is some
Hyperplasia.
discrepancy between the
So,
area by the
so
OCT
this updated
versus,
system is automatically
FFR.
measure the lumen area. So at this time we have a lot of debating portion. How do you treat, some FFR and imaging discrepancy, sock region, LAD main mechanism is under expansion. Is I'd like to hear some panel opinion or the moderator opinion.
Circumflex FFR is
Is it 0.9?
0.9.
Yes.
All right. So
It doesn't make sense. Yeah.
so what would you do there?
So, I initially I decided to the balloon angioplasty, and the next distal part is I try to apply the 2.5 cutting balloon, but does not pass well because of a very tight region. And then next, initially we do, this is a compliant balloon 2.5. Is I drag the match the distal end of a part, and then the next, looking at the zooming image, there is how much underexpanded the distal part of a stent. There's a 2.5. There is a definitely underexpansion. This is 2.5 compliant balloon. Looking at there is some band portion not dilated well, and then next.
Why don't you use a compliant balloon?
Some initially 2.5 cutting is not dilated, and then next, and then and then we apply the 3.0 cutting balloon. This is the
Cutting balloon?
Yeah, cutting balloon 3.0. Looking at the zoomed area, there is a some under-expansion, and next. And
So
then
what pressure
cutting
do you
balloon,
apply?
3.0 is up to 8, 10. Burst is 12.
Why did you do that? By OCT findings, the main mechanism of ISR is under expansion, right?
Yeah,
very
right,
small
right.
under expansion.
Yeah, right.
Not too much, intima hyperplasia. So, what do you think? I think it's a non-compliant balloon, the 275, something a little bit bigger balloon, hyperinflation. I think it's the first choice.
Yeah,
What do you
right,
think?
right. So there is some superficial calcium area, and that I'd like first some modified some plug lesion, and then additionally do non-compliant balloon. So I did 2 or 3 cutting balloon using 3.0, and then next this is cutting, try to modify lesion, and then I select the NC balloon is a 3.0 mid distal part. Proximal part is I applied 3.5 non-compliant balloon. And next. Okay, next. 이게 3.5인가? Okay, so this is the final immediate angioplasty. This is the several time applied 3.0 non-compliant balloon, inflate 25 ATM, 30 ATM mid part. Proximal part.
3.0 balloon?
Yeah, 3.0 balloon, the
distal?
mid part. Mid distal LAD.
Mid distal?
Yeah, proximal LAD, I did 3.5 non-compliant balloon up to 25 and 30 ATM. And next. So this is the non-compliant balloon. Next. This is 3.0. So at the time, I immediately rechecked the OCT again. Yeah. OCT shows how some change seen after balloon angioplasty. Okay.
So after balloon angioplasty, here is a finding. Just the distal part of the part of the coronary artery to the stent, there is a significant calcification. So as you can see, there is some dissection of the distal edge of the stent, but which is not significant. But stent is well expanded, around 3.0. Yeah, with a similar size of the balloon. So as you can see, here is some part is there is a eccentric expansion because of the protrusion, eccentric expansion because of a severe calcification at this medial part. Also, proximal part is well expanded, around 3.5, as you can see. So it's quite well expanded with balloon angioplasty.
At this portion, I applied 3.5.
Yeah.
So at this time, I'm gonna check the coronary angio again. Angio ready?
So this stent has been treated with DEB as well?
Not yet.
Not yet.
I thought it was in the history that it was treated with something a year later.
Not a year. So definitely
9 years ago. So it's been treated with DES and DEB.
10 years ago, 8 years ago, DEB.
Yeah. Do you know how long was the DEB? Was it treated the whole stent or just the focal proximal area?
Yeah, I don't have enough data. It's just it's performed another hospital. Okay, and you're ready? Should.
Great.
Okay, so I think LAD is already applied non-compliant balloon is more than 10 times mid LAD, prox LAD is expanded well.
I think it's quite enough. And so would you do DB again?
Yeah, DB again.
Right,
I should apply 2 long DBs, distal part 3.0 and the proximal part 3.5. And the sarcoosteum area is lumen 1.8. I'm concerned about the sarcoosteum. How do you think?
What about the main areas? Main is good?
Yeah, V-stand. They at the times they do V-stand. Could you show us the left main OCT findings?
By OCT findings, by any disease on the main?
Okay, here 우리가 쭉 메인까지 보는 게 있어. Okay. 요 전 거에서 okay, here is the main.
Okay. Auxiliary still to stand after the main. All right, this is guided.
Dr. Park, there's a little dissections at the end of the LAD stent area. Will you apply a small DES there or not?
You know, there is not flow limiting, just a small size of dissection. I think it's just the additional final DEB would be okay for treating that lesion.
So, you have already done DEB, not yet, right?
Not yet.
All right. So
That is our final step.
My suggestion, DEB again. I don't want to, double, drug stem for a relatively unexpanded, diffuse, stented area, and so just DEB. And circumflex concern, even, 0.9 FFR, I believe it, right? 1.29 millimeter minimum lumen area cannot predict the function itself, right? After the balloon inflation, there are some, some changes after the, balloon inflation. Why don't you do the FFR again for circumflex, right? It definitely 0.9.
30으로 해야 돼. 20.
All right, you don't.
랭스를 재봐 한번.
FFR 다시 썩 해보자고 하시는. 썩 FFR 다시 해보자고.
FFR 다시? 잠깐만, DEB 한번 해줘보고.
Is there anything more compromised after the main balloon, LED inflation, balloon inflation, circumflex social part?
Okay,
30.
Okay, say it again.
All right, angio gain.
Okay, I'm gonna check. Yes. 토탈 스텔 랭스는 얼마였지? 오케이, 엔진 한번 다시 체크해 볼게요. 테스트.
나이트로.
테스트. 오케이, 나이트로 좀 줘봐. 네. After nitro, we're gonna recheck the coronary angio. 우리 아트로핀 2개만 주세요. 라이트 조금 주세요. I think our final step is to draw corridor balloon for LAD and decide to treat or not treat the sacral region. Okay, angio. 갑니다. 자, 세게 찍어볼게요. 자, 풀샷.
Very tight.
Yes.
Spider view too.
스파이럴.
자, 스파이럴 한번 찍어. 오케이. 잠깐만 내가 할게. 자, 엔저 찍어볼게요. 자, 풀샷.
Looks
So,
tight.
yeah, I think left main is okay. Left main is okay.
Circumflex is always the most unpredictable one. Sometimes you can see a lesion
Yeah,
that looks
right.
tight, but the FFR
이게
is...
DBJ 조금만 더 빼놔.
And his LV function is normal as well, right? Danggu?
Yeah, right. Left
not
main
as
ventricle.
impacted.
Yeah.
Okay, what would you do there?
So, frankly speaking, I'm gonna treat the sacral region.
Why don't you do the FFR again
Yeah.
for circumflex, right?
The
You want
problem
to
is
move on another loom,
You can do whatever you want to do.
Okay.
You know, the problem is my fellow is already checked FFR.
But Dr. Park, you have told us that the changed already, but thallium defect was there in the circle area.
이 쌀림 한번 보자. LAD만 국한됐는지 서클만 국한됐는지 한번. Okay, we're gonna show again. Recheck the 쌀림.
Okay.
DB 일단 뒤에 어플라이 주세요. DB. Okay, I'm gonna apply the DB for the distal LED part, and we require long DB, the 2 DB LED.
Okay.
Treat.
Teguh, we'll be back and after
Okay,
the
got it.
Dr. An's cases. Okay, Dr.
Okay.
An.
Yes, good afternoon,
Okay.
Dr. Park.
Dr. An, can you hear me?
Yes, I
Okay.
can hear you.
Yeah.
Dr. Lee, could you explain?
Yeah. Let's see the case. This case is a 60-year-old male was admitted for the evaluation of abnormality of CT coronary angiography. He underwent the PCI at the proximal to mid-LAD 9 years ago in another hospital. The CT coronary angiography showed significant in-stent restenosis in mid-portion of the stent and showed mild to intermediate stenosis at the proximal to mid RCA next. He has a past medical history of hypertension and hyperlipidemia and smoking history. Yeah, clinical presentation is silent ischemia. Yeah.
So can you see the coronary angiogram?
Yes.
Okay, this is the patient angiogram. He implanted he had the 9 years ago he had the PCI at the cipher stent.
Yeah, the stent information is not recommended, recorded.
But it looks like the cipher.
Yeah.
Is it?
Yeah.
So the instant restenosis case. So we assigned this patient to the ROTA ISL random trial, assigned to the rotabulation case. I'd like to see how to do this procedure. So initially we evaluated the OCT. Could you show us the OCT? Long, please. We don't have a specific, could you show us the OCT? Okay.
Yes,
we don't have any specific stent information, but based on the OCT findings, stent would be the 3O stent. The fibrosing minimal neointimal was shown, and mostly fibrotic tissue. So lumen is maintained here, but proximal portion of stent, lumen is some calcification out of stent. Inside of stent there is some calcification. And you can see the calcification inside the stent, and lumen is tighter, mainly fibrous tissue. Some calcification, calcification means neoatherosclerosis.
Stent expansion is good?
Yes,
Yeah.
3O, and here is the narrowest portion.
Mainly intimal hyperplasia, right?
Yes, right. So proximal stent edge, the lumen is good. So can you show us a spider view? Another view, another view, another view. Okay. So I'd like to start with the rotabulation with to effective deburking. I'd like to select 2O. I already insert rota wire. Areocranial, please.
Areocranial.
This is a French jockeying guiding catheter.
Does the rota stent protocol require information regarding ischemia? As far as I heard, we don't know whether this instant restenosis is causing ischemia or not.
Got a big burst, 2O.
Yeah.
Without rotabulation with a small burr, may have some, right. More plaque embolization, etc. Very slow.
And I think guide support would be an issue too as well, because the big burr and the stent may be in your way a little bit here and there. So.
도장. Remove please. Remove freeze. Yes, I fully agree with you. Big ball can make the large debris and then high risk of the no reflow. But to simplify the procedure, I like to start with the big ball 2O. And ready?
Ready?
And Flushy, please. Flushy. Flushy.
40.
Ready?
He's sleeping. Great. Better.
Okay, getting better. So I'd like to change the, I think no further or tabulation, no option. So I'd like to change the wire to the conventional wire. And then I apply the scoring balloon. And finally, DEB is my plan. Do you have any comment?
So high pressure inflation.
Yes, high pressure inflation, but using the scoring balloon first and then high
Alright.
pressure inflation.
Okay. You want to say, all right, Dr. we will revisit very
Okay.
limited times, and so you want to
Okay.
move to next room. Jung-Sun
Okay.
Kim, Dr. Kim.
넘어오라고요. 네,
All right.
we are in.
도영강,
Yes,
can you hear us?
yes, I can
Alright.
hear you. And
I cannot. I don't
Dr.
hear.
Kao can I hear?
Kao,
Please check.
Kao.
Yeah.
I'll take this one.
Dr. Kao,
Yes.
how are you?
Yeah. Oh, okay.
All right.
I can hear you now. Yeah.
Okay.
So
Thank you
we
for
are in the
joining
middle
us.
of an interesting case. SJ, can you hear us?
Yes, we can hear you.
Okay. Thank you for this kind invitation. I'm happy to work with the Dr. Khan and Dr. Park here. I'll let him introduce the case now.
Okay. Can you show the slide? Yes.
Right.
She is an 80-year-old female complaining dyspnea on insertion 2 months ago. She had received PCI at proximal to mid-LAD and diagonal artery 11 years ago with a cipher stent. She received mid-LAD stenting with 3.0 and 3.5 cipher stent, and because of the diagonal brain gelling, she received provisional T stenting with a 3.0 cipher. And then after 11 years, the dyspnea on insertion was next. And the angiography showed we checked the angiography, and the angiography showed the instant restenosis of the LAD and diagonal cipher stent. Next, her echocardiography showed depressed LV ejection fraction 42% and normal renal function, and Silen's spec showed a large defect on the LAD territory. We checked the angiogram, and the LAD and diagonal cipher showed severe instant restenosis, and RCA disease was FFR negative. So we decided to treat the patient for her ISR lesions.
Would you show us the baseline angio?
Yes, okay.
Yeah. Please, let's go to the first angio.
Great.
So the history is a very interesting one. She had a provisional T stenting
Yes.
with the old cipher. So that was more than decades ago. She had critical restenosis at the bifurcation. And this was the initial shot because you can see the distal abdominal aorta is quite tortuous. But we have set up a French guide without too much of a difficulty. And this is the first shot today. So we can appreciate the previous cipher at the LAD diagonal bifurcation and a very tight stenosis just distal to the bifurcation. And also the rest of the stent looks relatively nice. And the diagonal ostium is also somewhat diseased. But these two are both big vessels. Next. This one is a shot from the LAO cranial, again looking at the bifurcation. But from this projection, we think the diagonal ostium maybe is not that severe. But we are not sure whether it's a really bifurcational stenting because the previous T stenting, it could be a geometrical miss at the ostium of the diagonal. Okay, so we started with the IVUS run. We want to find out what's the mechanism of this restenosis. But this is a store loop. You can see the IVUS probe cannot be advanced into the LAD. So obviously the stenosis is really tight. Next.
Next.
And then we run a IVUS from the diagonal. No, we did a diagonal.
Yes.
IVUS from the diagonal.
Yes.
And go
sorry.
back.
Yeah.
Go back.
Okay.
Go back. I did not, I'm sorry. I did not record the Cine for the IVUS run into the diagonal, but we can review the IVUS,
Yes.
which is quite interesting.
Yes.
The diagonal?
This is diagonal pullback.
Yeah.
And the diagonal pullback shows the vessel size is about 3.0, and you can see the old cipher stent, 11 years old. And you can see neo-intima hyperplasia. Because the stent size is about 3.0, and we implanted 3.0 cipher stent, and we can say there is no under-expansion. Stent is well expanded, but there is some neo-intima hyperplasia, especially in the ostium of the diagonal branch. Maybe it would be very calcified lesion with a stent, and it could be a neoatherosclerosis, but there's some calcified neoatherosclerosis and very tight disease, just proximal. And you can see that here, from here, this is the diagonal opening.
Looks
Here,
like we don't
yeah.
have stent around here, right? Maybe a small gap.
Yes, there was a very small gap at the 10 to 2 o'clock position, maybe a geographic miss correlated with the provisional T stenting. This is the LAD 3.5 cipher. The cipher stent is well expanded, and there's almost merely no neo-intima hyperplasia. Stent result is very good. And this is a proximal native disease.
Yeah.
Oh, yes.
So after this run, we discussed
Yes.
between ourselves, and then we decided to do a very small balloon dilatation on the LAD and then do a IVUS run.
Yeah.
Just try to find out the mechanism. So after this diagonal run, we use a 125 balloon. The balloon cross relatively easy and inflated at 10. Next one.
Next.
And then after these, we run the IVUS into the LAD.
Yes.
Can we have the LAD IVUS?
Yes,
now?
this is LAD run from the mid-LAD. The mid-LAD shows it's a nearly normal vessel with a size of 3.0, and this is an old cipher, 3.0 cipher. And size is good, stent is well expanded, and there is a little bit neo-intima hyperplasia, but it's well maintained during the 11 years. And the stent area is very good. And there is some neoatherosclerosis. You can see some calcification inside the stent. And going to proximally, a little bit faster, yes. Here, from here, you can see just distal to diagonal opening. There is very severe neo-intima hyperplasia with calcification and some stent stretch, some anatomical abnormality. And then proximally, the lumen is relatively maintained.
Yeah. So we think that this case is eligible to your randomized trial.
Yes, that's right.
So she was then randomized into the rotablation.
Yes, that's right.
And then we
Okay,
will. I'm
what
sorry.
did you do there, Cole?
Yeah. So for this case, I want to do rotablation into the LAD, and also probably rotablation into the diagonal.
Yes.
And after that, I will send in 2 regular wires, and then balloon, and then DEB afterwards. Unless we have flow limiting dissection.
Yeah.
At that moment, maybe we have to think about stenting.
Yeah.
But basically, we want to finish the case with rotablation and DEB.
Yeah. She was also enrolled in the ROTA ISL trial and randomized to ROTA group.
Rotablation, right? Yeah.
Yes,
However,
that's right.
Your distal part of LAD, actually, there are some combined, a little bit under expansion. The calcified plaque is very short segment, even in the encircling calcium. Actually, practical point of view, we can dilate with non-compliant balloon sometimes, right?
Yeah.
Yes.
Yeah.
Okay.
Yeah, I think you are right. We will do a nice proper balloon dilatation.
Okay.
If there is no dissection after that, we do DEB.
Okay.
If we do have flow limiting dissection, then we have to put in a DEB, DS. I'm sorry.
Okay, thank you.
Shall I show
Kao
you
Juyeon
the
will be
LAD?
back. So we're gonna move another cat room. Jung-Sun
Okay.
Kim, Dr. Kim.
Okay.
Okay, let's go to diagonal branch.
Yeah.
Okay. So you're gonna do rotablation.
3O,
High pressure
high
balloon.
pressure.
Just want to give a.
저희도 투짐에서 해서.
그래요? 네.
투짐에서 들어가겠습니다.
I just want to give a general remark. Well, for Rota, in a very short lesion, lesion like this, I think we will see how good the operators demonstrate to do proper procedure, because we have to advance the burr very slowly. Otherwise, if the burr jumps into the distal to the stenotic area, we will very easily get burr stall. So it's very important to advance the burr very slowly. And secondly, we have seen a very nice demonstration of, in the first case particularly, co-registrations of OCT and coronary angio. So with this co-registration, we can have we can very precisely define where the region of interest is. And I think in the very near future, we may be able to use QFR also, which may enable us to, at the same time, assess QFR, so flow, as well as the anatomy. Of course, we need studies to validate this.
Thank you. Kim, Dr. Kim?
Oh, yeah.
Can you hear me? All right. So you're on the screen?
Yeah.
Could you explain your cases?
Yeah, it's my great pleasure to join live demonstration in complex PCI. At first, we would like introduce our team, Oh Seung-Kwon. Next to me, he will help me today. And at first, he will explain the case. Please.
Okay. A patient is a 66-year-old female. Was visited to the outpatient clinic due to dyspnea on exertion, which started 3 months ago. He underwent a routine medical examination. For that examination, coronary artery disease was identified on CT. He doesn't have a coronary procedure before. Next. She has a risk of hypertension, hyperlipidemia, and the family history of coronary artery disease. So the presentation is a steroangina. Next. So we directly checked the coronary angiogram, which showed the left main bifurcation disease with the short left main stem. The distal circumflex artery also has a stenosis. The right coronary artery was a diminutive RCA. Her syntax score was 23. Next. So today we're going to deal with the left main bifurcation as well as circumflex artery disease.
Yeah, it's good. So can you see the angio? Angio, please.
Not yet. Okay.
Yeah.
Great.
Yeah. So this case is a short left main, so it is not so easy to negotiate to the LAD. So it takes some time. So we prepare just before for this patient. So in this case, there is a significant stenosis of circumflex, distal circumflex, and left main bifurcation, especially proximal LAD and distal left main. So our plan, we have a plan to perform the PCI to the distal circumflex and left main. So in this case, but the RCA was diminutive, so circumflex is very big. So that means a left dominant coronary artery system. So in this case, we have two possible plans. First one is just crossover to the LAD to the left main, and the other plan is we can do the two-stent technique. So, but before do the procedure, we would like to check the circumflex ostium and LAD with IVUS. Is that okay with you?
Yep.
Yes. Yeah.
Also, the other thing is that this patient have no stress test until now. So do you want to do the FFR to the circumflex? There's a circumflex to check the ischemia. I think angiographically it's very significant. And also this is a left dominant artery, so I think in my mind, personal experience, we don't need to do the FFR for the circumflex artery. So at first, we will do the
anyway. Just check it.
Yeah. It's okay. Yeah.
Just go with that first. Just save time. Yeah.
아니라.
So we will do the IVUS from the LAD. Yeah, mid LAD to the left main. Do you have any question for this case? So here is that. It's okay?
Yeah.
Yeah.
Normal looking.
Circumflex.
Yeah. LAD.
LAD.
Yeah, this is a areocranial view. So we pull back from the mid LAD. There is a little plaque burden. Size of vessel is 3.25, around 3.25. Then there is some plaque between 3 and 9 o'clock. There's another branch here. There's a little stenosis here. There is some calcified plaque between 12 to 3 o'clock. And this area is vessel is very huge, and there is a lot of plaque burden. This is approaching to the LAD ostium. So it's around LAD ostium. Yeah, there is a large amount of plaque around the ostium. And there is a circumflex artery is approaching around 9 o'clock, and here is a left main.
Some disease on the left main, distal?
Yeah, but not that significant, yeah. So we will do another IVS from the circumflex. Flush.
No FFR for circumflex?
Oh, no.
Maybe we have
Do you want
already
to?
done.
Yeah.
Not yet?
Already
Not
done?
yet,
Not yet, not yet. So I'll do the IVS at first, and then if you want, we do the FFR. Is it okay, dear?
코달 하겠습니다.
코달, please.
So, Dr. Kim, what's the MLA in the LAD?
MLA?
LAD. Yeah, we will check. Just do the IVS right now. So after IVS examination, circumflex, we will check again. Yeah.
Big vessel, right?
Yeah, big vessel and more. Yeah, distal. Yeah, here. Yeah.
Very
Yeah,
big.
pull back. The vessel diameter is around more than 4.0. Very big vessel. There is some calcified plaque around 6 o'clock. And there is a huge plaque burden between 6 and 12 o'clock. Yeah.
More than 3 between the 4, lumen areas, right?
Yeah.
5 something. Tightest portion?
Yeah, here is a possibly minimal lumen area of the circumflex.
Tightest portion would be minimal lumen area, 3 or something, right?
Yeah.
Those measure
We'll
that.
check.
That's almost it.
And the other important point is the circumflex ostium. Just approaching to the left main.
Big, huge.
Yeah, here is a ostium of circumflex. What do you think?
Not pretty much plaque.
Yeah.
That's right. Circumflex ostium.
Yeah. Because I think in Asan Medical Center already reported more than less than 50% stenosis of circumflex ostium at the time, 3.7 square millimeter and 56% of stenosis. More than 6% of stenosis could be to possible cause a jail of the circumflex ostium when you do the one stent crossover technique. Yeah, so I think we will check. Then I think in my mind, I think it's more than 3.7 square millimeter more than.
So what would you do then?
Yeah. So in this case, we will do the stent to the circumflex distal, and then we just cross over the left main.
Circumflex stent first?
Yeah.
Would you consider cutting balloon for the circumflex focal lesion? It's kind of calcified, and so I think get that prepared well will be a good thing as well for the future.
Yeah, I think it's one of possible. Yeah, it's strategy, but I think it's possibly we can do the simple balloon angioplasty.
Jung-Sun, would you show us angiogram again?
Angiogram.
Angiogram. Great. Okay. In fact, in our lab practice, as I'm gonna do, I really try the FFR first.
FFR first,
Meaning minimal lumen area, just 3 millimeter square. Even the large Japanese myocardium supplied circumflex vessel, lumen area I think is big enough, and the region segment is not too long. I don't know exactly what the FFR value is. However, personally, I think is FFR first, and then on a treat or not treat decision making, we're gonna do that.
Yeah, it's good.
That is our policy.
Yeah, good strategy. We'll do the FFR.
SJ, if you look at this though, there's a OM branch that has a significant disease in it as well. So as a pretty big branch, so if you want to check FFR, would you need to check into that one as well?
I don't want to do the
you just want to do
this. Mainly
just the circumflex,
right? Big circumflex artery. Treat or not treat, it's still almost during the last 10 years, negative FFR, we never treat. So the reason why is we want to make a large series of data, 0.9 FFR, no MACE rate. Whatever, angiographic stenosis, that is ours, FFR T4 data. So, okay. Dr. Yeow, you want to move to the very limited times, and so Dr. Teguh back, we will visit again.
No problem,
Okay, can you hear me?
Okay.
Okay, we finished this case already. I'm going to show the thallium scan finding. Can you see the reading of a thallium scan?
You can clearly see that.
Okay, looking at the thallium scan interpretation is by expert reverse large size decreased perfusion defect in the apical anterior and apical septal. That is definitely the LAD portion was only, definitely. Yes, so. And we applied after region optimization using the cutting 3.0, 3.5 non-compliant balloon. We finished all region preparation, and then we applied the 3.0 the B Brown, and then proximal we applied additional DB is a 3.5 and the B Brown, and then next. And then somebody, I think definitely suspicious of a sarcoosteum is, some fatigue or sometimes my decision making to be confused. And I rechecked the FFR again, the sarcoosteum, and then next. Okay, next. And then we removed the sarco wire, and then the FFR equalization. Usually we intravenous adenosine 140 micro is our protocol. And next, I pushed the FFR wire and then checked FFR. We doubling the adenosine. Is the lowest FFR value is 0.88. That means FFR is okay, and that is definitely well matched the thallium scan. And then we the pullback the FFR is the step up point is definitely the neo-intimal area, but 0.88 functional is okay. And then remove the whole wire LAD, and then next. And then we finally checked the the target area. As this is a co-registration OCT again. Could you show us the OCT finding? Looking at the distal part, it's well expanded. There is some protrusion of a plaque. Is compared to the
You don't
first,
see the image.
Oh, can you see OCT?
Not yet.
Yeah, okay. OCT 처음부터 다시 안 보여주나 봐. 이 중간에 트랜스퓨 이걸 잘 못하나 보다. 좀 이렇게 얼른 해주세요. 됐어? Okay, okay. Can you see the okay?
Yes.
Okay, we play the OCT. This is distal end. Is just the minimal dissection is okay, and the prior lumen area is much inflated. This is end of the drug-coated balloon application, and the lumen is fully expanded well. As compared to first imaging is much improved, and then this is a proximity part is fully expanded well. And we inflated 3.5 is applied drug-coated balloon, and the edge of the proximal is okay, and left main is there is no significant dissection is okay. So and then next. So and then we finally checked this is arteriocranial view. We can see flow is okay, lumen is much improved, OCT finding is okay. And next. And this is the, array coral view, and the left main is okay. Circle is intermediate, but functional is definitely okay. And next. And then this is the spiral view, and the final result is okay. So I finished my case.
Great. Would you show us a previous view?
I have a question.
It's previous view.
Previous.
Previous.
All right. Array coral view.
아니, previous.
All right. Great. So I think this is not before treatment.
This is the original one.
Last
Yeah,
picture.
that is the last one. Oh, 이건
Last picture.
Before.
This is the first one.
Okay, got it.
Great, that one.
Dr. Duk-Woo.
Yeah. Yes.
Yes, I have a question. If we look at the data from the deferred trial, 15 years follow-up, we can safely defer a lesion if the FFRs at that time they use a cutoff of 0.75 until 15 years. Mm-hmm. But I'm just wondering whether this holds true also for in-stent restenosis. What do you think? Here, of course, the FFR is quite acceptable, but this is the case with in-stent restenosis.
Okay, so we want to see that we don't have too, solid data about that. However, I think it's not too much different with a native artery stenosis. And 0.9 FFR, meaning is absolutely no MACE during the 5 years, 10 years data. So we have it, right? Okay. So that is a clear message from the, FFR believer and non-believer. Actually, so whatever stenosis is, angiographic is, FFR 0.9 is absolutely, the best number of MACE during the almost 10 years follow-up data we have. Right?
I tend to agree with you. Because this is a case with neo-vascularization.
Right.
So it's not a case with
our prior principle is based on native vessel, but I think
the meaning is
function would be same.
We don't need a preventive treatment, right? We know that. It's happened. It's a patient has some symptoms. Why not we're going to do is another angiogram. However, still absence of ischemia, no ischemia at all.
Yeah, right.
However, there are some difference because we have to treat them. Oh, no. So, what is stand is preventive treatment? No, I don't think so, right? That is clear message. Dr. Wang,
Teguh, don't worry about.
Would you still wanted to treat the circumflex?
No, I don't treat.
No, right. Okay.
Great. This
is Teguh Santoso. Next year, I'll let you know if the patient is okay or is not.
Okay. We're gonna move another room. Dr. An here.
Okay. Thank you.
Okay.
Yeah.
But
yes,
that's definitely the lowest in-stent lumen size that I've seen with the normal FFR. 1.29, but still a normal FFR, which is, amazing.
Absolutely minimal lumen area cannot predict functions. The meaning is there are lots of variables, lesion length, morphology, etc., etc. And so minimal lumen area is nothing.
You see you see with your eyes, 1.29 luminal area, we all actually, our antenna will go up and stenting or do something.
I don't believe my eyes.
Yeah,
I don't believe my eyes. Right?
So that's good.
You believe in number, right? Number will be better.
Right.
And also it's a difficult treatment. What you do is not easy. Even if you want to treat that circumflex.
Anyway, just leave it alone. Is the current practice the best? Absence of ischemia, I don't want to touch, right? And we're going to study, the prevent trials. So there are negative FFR vulnerable plaque over there. So why not? We have the answer, and so we're going to do the treat and medical treatment. That is our current conducted studies. However, any cases 0.9 FFR is absolutely free of MACE. I believe that. Okay, Dr. An?
Yes.
Okay.
I already finished my procedure. After rotabulation, I applied the high pressure balloon and scoring balloon. Finally, I applied the 3O, the DEB, drug-coated balloon, at least 30 seconds. This is the final angiogram. And then I also evaluated the OCT. Can you see the OCT, final OCT imaging? Long, please. Here is the distal. My focus is the proximal stem portion. So of the long, please. So after the ballooning, the lumen is maintained. Some small rupture, but it doesn't matter. So here is the narrowest portion, but the lumen is well maintained. So the tight stenosis disappeared after the high pressure ballooning and something like that. There is some dissection, but theoretically not big. Not big. Lumen is very big. So, can you see the final angio?
Yeah, it looks good.
Okay, looks good. Another view. The spider view, please. Yes, we can spider view. So we can see some dissection flap, but there is a stand. So I believe that it doesn't progression to the distally. So the lumen is good. Flow is TIMI-3. I'd like to finish my procedure.
Great. Thank you for nice cases, Dr. An. And so we want to move Dr. Kao, Paul Kao. Can you hear me?
Yes.
All right.
Yeah, we can hear you. We are almost done here. Almost. So let's go back to the rotational. So we left you after the IVUS interrogation. We decided to go for rotablation. And this is the shot after the 125 balloon and IVUS. So the wire is in distal LAD, and this is a 175 burr at 180 RPM. So we did this relatively gentle and slowly. We did not push the burr too much, understanding that this is an instant restenosis, especially at the bifurcation. So if we push too much, maybe the burr will just jump and stall. But this was the first pass, cannot go. So we increased the RPM to 190, did the second run.
Yes.
Next. And this was the second run and 190. Again with slow but persistent push, the burr made the pass. Literally no RPM drop. Next. And also, by the way, she's having a second-degree AV block to begin with. So we give her low-dose atropine, also a venous sheath in place, just for need for pacing. But she never developed bradycardia. So this was the shot after rotablation to LAD. Looks fine. Flow is good. Next. So we decided to go into the, this is a polished run. Same RPM. Okay, next. And then after that, we flipped the wire into the diagonal, did the rotablation into the diagonal also. And again, at the proximal part of the diagonal, right after the bifurcation, there is some resistance. But at 180, we can make the pass with the first run. Next one. This is the shot. Again, flow is good, no slow flow. Next. So we rewire both arteries with the regular workhorse wire, and this is a 3.0 high pressure balloon inflation. This was done at 16, I believe.
Yes.
Next.
Next.
And this is up to 20, but still we do have some waste here. Next. So this is 24. I think the waste is gone. Next. And this is diagonal, again, at 12 to 16. Next. Okay, next. So after that, we think there is still something at the LAD right after the bifurcation. So we did the IVUS run again. Next. IVUS. And we can go a little bit more proximal, just before the bifurcation. Yeah. So the distal part of the stand looks fine. No dissection, minimal hyperintima. And okay, let's go back a bit. Yeah. Okay, so this is where we are just distal to the bifurcation. You can see the stand looks like there's some, deformity or something, or calcified neointima. We cannot tell exactly, but the proximal part is fine.
Yes.
Okay, next. And we also IVUS the diagonal, also more proximal, close to the bifurcation. Yeah. Diagonal stand was also good. Okay, stop here. And the diagonal part looks relatively okay at the bifurcation ostial area. Okay. So we decided to inflate the LAD again with a slightly larger high pressure balloon, which is a 3.5. And this is a 3.5 at 20. Next. So essentially no waste. Next.
Up to 24.
Up to 24, exactly. Next. And this is the picture after ballooning. We think that everything is fine. No flow limiting dissection, and the waste is gone. We believe that the formed sand strut is somewhat fixed right now. And then we go for a DEB kissing balloon. So these are two 30 by 30 Pantera Lux inflated at 12.
Yes.
And then inflation was kept for 50 seconds. Next. She had some chest pain and some ECG change, but she tolerated the procedure well. And this is the shot right after the double ballooning. This is where we are right now. Okay?
So Paul, why did you decide to do a kissing DEB?
Well, because from the IVUS, we believe that the problem is really located around that bifurcation area. So if we were to use one dB without a balloon in the diagonal, I'm afraid that there's some plug shifting or stand flow divider shifting. But then if we were to use a regular balloon in the diagonal, then the proximal part of the LAD will, the DEB will not contact the vessel wall too well. So we decided to use double DEB. Okay.
I'm impressed with how OCT actually, for in-stent restenosis, especially stents that a long time ago, you can see calcification inside the neointima. While IVUS can really tell you the composition in that part. So I think in your trial, some analysis of some of the cases will be done with OCT, some will be IVUS. Look at the composition of the neoatherosclerosis will be quite interesting, because if there's a lot of calcification, maybe rotoblader may be very helpful to get rid of some of that material, just like a calcified lesion. But IVUS, I don't think you can tell the difference.
So no, I think you're right. Well, in the beginning, we were discussing whether we should use IVUS or OCT. But because in the beginning, the flow, the narrowing was so tight, the flow was actually TIMI 0 to 1 in the distal LAD. So we don't think that the OCT will give us a clear image unless we did something to restore the flow. But then it's not the original picture. So we decided to use the IVUS, which
So would you do DB?
I think DB already
done. Okay. Kao. Okay, thank you for nice presentations. So we very limited time. So thank you for that.
No
Dr.
problem.
Kim,
Thank you.
Jung-Sun Kim. Okay.
So we already did the FFR. Can you imagine the value of FFR?
No, absolute no.
So FFR, can you show the FFR value? So as you can see, FFR was 0.85. And minimal lumen area of circumflex is a 2.9 square millimeter.
0.85.
Yeah, 0.85.
All right, I don't want to treat them, right?
Oh, yeah.
What would you do there?
Oh, yeah, I agree, fully agree your opinion in current situation. But in the future, if there is some progress of the circumflex artery, so it's somewhat difficult to treat at the time because we already cross over from
right.
the
So
LAD
maybe,
to
Dr. Kim, it's just in cases. So we have to learn. You know, even in the whatever the 70%, 80%. If you believe 0.85 FFR value is absolutely absence of ischemia, we have to try the FFR. That is guidelines 1A, right? You have already changed a lot concept-wise. Okay, so what would you do there?
So just I think as your recommendation, I just put a stent from the mid LAD to the left main with a 35 millimeter stent, 3.5 in diameter. So that is our plan.
Did you measure FFR on the LAD?
LAD did not. But LAD is also another issue because LAD minimal lumen area around 4.0 square millimeter.
So did you check the FFR from the LCX beyond the distal part of the stenosis? There is the stenosis at the proximal part, and also the another stenosis in the distal part. So you already checked the FFR around the proximal part?
Yeah, in this moment we already checked the proximal part of the FFR.
Yes.
Yeah,
but maybe in the middle, there is a stenosis in not the OM. Beyond distal, not this branch. Before that branch, there is a PL branch. So there is also the stenosis. OM branch is stenosis, and also the PL branch is also the stenosis. So there are 3 branches. So I think that it's better to check the intermediate one. So the OM branch is stenosis, and also the mid part, there is a stenosis. And your wire is getting into the more distal, more RCA side. So maybe it's better to check the intermediate. There is also I think that's a big supply. I mean that.
I agree. I fully agree. Understand what you mean, but I think when we check the distal part of the FFR, proximal and distal part of FFR maybe decrease 0.8.
Also, Dr. Wong.
Yeah.
You don't have any information for this patient, evidence of ischemia since FFR, previous FFR? No? You have no idea?
Yeah, we don't have.
We don't have,
do the FFR and do not have any stress test before in this patient.
Okay. So what would you do? You want to try the stent for that, right?
Yeah.
Okay.
Left main. Yeah.
All right.
It's best focus on the left main in this case.
Okay. Yeah. Dr. Kim, we will be back after 10 minutes.
Yeah, thank you.
15 minutes later, right?
Yeah.
Okay, thank you.
Yeah.
All right. So you want to move to the featured lectures. And Dr. Muramatsu, master of CTO-PCI, the latest device, technique, and strategies in Japanese fashion, flash update.
Thank you, SJ, and I honors to be here. And today I talk about the current PCI for the CTO region. As you know, this is a very famous algorithm of Asian CTO club. First of all, it is very important to careful reading of the angiogram. If you can obtain the cardiac CT, it is more informative. And if you have an instant restenosis, they recommend it across both systems. And focus for the proximal fibrous gap ambiguity. If you don't have any information of the proximal cap, it is better to help for the IBUS guided entry point wiring. And for distal vessel qualified, plus interventional collateral presence, it's shift to the retrograde approach. But not interventional collateral channel, and the distal vessel is very good antegrade at first. So the antegrade method is first of all, as you know, the wire escalation, and if failed, the dissection reentry or part wire and the IBUS guiding. And finally, the retrograde and antegrade, the IBUS is very important, the guided wiring or sometimes start techniques, and the retrograde also the IBUS can confirm the where is the wire in. I will show the reading angiogram. Appropriate angiogram is very important. This is a very beautiful bilateral injection of the CTO, LAD CTO vessels. So it is very important to know panning and a dual injection. At first, of course, the antegrade injection after collateral filling to this main branch. And the collateral angiogram is very important also. This is in the septal channel, and the focus for the septal channel, and the plus, where is the epicardial channel come. And how to find the appropriate collateral channel. This is the right coronary CTO. It looks like collateral came from the septal channel. However, carefully you can read the collateral is not came from the septal channel. First of all, another channel came from the atrial channel. As you can see, this is a spider view. It looks like a nice view. However, it is very difficult to read where is the anatomy of the collateral channel. At that time, the areocranial view is very helpful. The same patient is very tortuous, the atrial channel. It is quite difficult to overcome this channel. So the same patient, they look at the, looks like a septal channel, but carefully areocranial view, the non-septal channel came from the suck, the small epicardial channel to the PD branch. And this is came from the suck. As you can see, sometimes connected to the PD branch like this one. So if once we notice this collateral channel, it's not difficult to automatically. This is the SO03 wire, and a very fine wire, and it looks like this one. And there's some resistance, but not push at all. The rotation, the mainly, and finally getting through the small channel like this one. So it is very important to carefully check angio retrograde, searching the channel from the CTO these vessels, and consider the appropriate direction to watch the epicardial channel. And sometimes powerful injections help you where is a small epicardial channel. Not tip injection is sometimes not not enough to clarify the small tiny channel. And the septal channel is relatively easier, and this is each guide wire is characteristics was shown here, and mainly the Seung-Ho, the SO03 is the main guide wire, but sometimes I prefer to use the Seung black. This is the septal surfing. The septal surfing is not easy. It looks like very few small many channel, but quite difficult. This is a very shallow types the septal channel. At the time, the septal surfing is sometimes can do it. And SO03 black and the broom type, the shower type septal channel, except the relapse-free channel goes and not push strongly. The rotation is the main manner. Not too much concentrate one channel. The change to another channel rapidly. And the epicardial channel also very difficult to see where is the epicardial channel came from. This is a septal epicardial, very tortuous. There are two different view, areocranial, this one. And try the SO03 first choice, and with Carabel, I recommend to the Carabel support. And the two different views, they're sometimes necessary to guide the injection to confirm two different view the wire into the tortuous, the epicardial channel. The moving of the guide wire is very important to according to the heartbeat in the conform to the in the collateral channel. And and finally get in this the distal PD branch, this one. And depend on the method tortuosity, they're using the Sion change to the SO03 wire for the tortuous area. And the IBUS is also very important. The where is the location is both wire in the true lumen or both wire in the subintima space, and one wire in the subintima, one wire in the true lumen. So this is very informative information for doing the reverse cut. And also sometimes the knuckle wire is very helpful. For example, like this very long. And also this is also the stent was impressed, and the stent was the break into the CTO portion. This is quite difficult to integrate approach. So at the time, should be necessary to retrograde and both wire into the subintima space and make a intentionally knuckle shape to surrounding the previous stent. And the IBUS show us where is the wire location, and wire into the fourth lumen, and the stent was here, and wire in the side of the stent, and back into the proximal portion in the true lumen. So the the stent was impressed using by the guide extension techniques, and wire into the intentionally make a knuckle shape, finally the different way to make a different course surrounding the previous stent implantation. So knuckle wire is a key issue. It's a filter types, polymer jacket type guide wire is appropriate. Along CTO, the both guide wire is subintimas, and the 19 degrees bend, the guide wire tips and support microcatheter, and don't inject dye, and don't into the side branch and the injury area which created by stiff wire. The guide extension is another important technique for not only for the usual PCI but also the CTO, like this one, the guide extension. Relatively easy to get into the retrograde wire in. And finally, I try to how to educate the PCI for complex CTO. So I already have NPO organizations. So I try to the training for the foreign young doctors, including the Japanese doctors, and make better models. This is an integrate frontal lateral view, the two-dimensional wiring models using by the both dimensional wiring. The wire into the subintima space, but getting back and trying to get into the CTO lumen. Now successfully passed. And another model is a retrograde model. This is a beating heart model, and retrograde wire going to the channel and follow the microcatheter, and the tip injection by the tip injection to make where is the channel course. This is the channel course, and trying to exchange the retrograde wire in and reach to the other side. So this is a training for the retrograde approach. This is a CTO portion also that can do the reverse cut. And I already doing like this training center and each countries. So take home message, retrograde approach has big impact for the CTO-PCI. Even detail appropriate reading of the angiography is a very important key issue. And two important issues, how to cross the tiny tortuous channels and how to cross the CTO retrogradely. And compared to the antegrade approach, there are some pitfalls in the retrograde approach, so it is necessary to obtain how to bail out from the crisis of the complication. In the future, training and educational organization will be more important role for the young interventional cardiologists. Thank you for your attention.
We're going to move next live demonstration session. Before that, we're going to drop by Dr. Kim, Jung-Sun Kim. Can you hear me?
Yeah, here it is.
Okay.
Yeah. So we just finished the procedure. So as you can see, we present 3.5, 38 millimeter derogating stance. As you can see, distal vessel is a 3.0. So we low pressure at first, and then we high pressure to the proximal part. Then we did IVUS. At the time, stand somewhat expanded, especially around the LAD ostium. So we did a 4.0 non-compliant balloon and post-dilation until 14 atmosphere. So here is a final result, as you can see. So here is the final result. And then we did the IVUS. IVUS, play, please. So stand expanded, 3.0. At the distal part, there is no dissection, and we're expanded. Just the proximal, go for the proximal part. Then minimal stand area, minimal lumen area at the time before the intervention, 4.0, but increase at 9.7 in this point. And proximal part of the left main is well opposed to the vessel wall. So just we finished the procedure. And also it's a meanwhile we did the FFR to the distal circumflex as you recommended. At the time, FFR dropped to 0.65. So there is a two drop. First drop is distal part around 14 at 0.2 to the distal part, and 0.15 is the proximal part. But we just put a stent proximal, LAD, mid LAD to the circumflex, and finish the final. We finish the procedure and we can get a final result. Is there a question?
Okay. Any other comment on that? Okay, thank you. Dr. Kim, nice presentation.
It's my great pleasure. Okay. Yeah, thank you.
We're going to move last live case demonstration sessions. Antonio, once again, Kibesung, Dr. Adraju, Dr. Ashida, Dr. Ajam, Dr. Chiam, Dr. Kwon is here? Dr. Hirohata, Dr. Noguchi, Dr. Chui, Dr. Wagatsuma. Okay, please come on the stage. Okay.